I think it was, it went well beyond fingers crossed and ad hoc. I think what you've done over there is very, is quite fantastic, and it's great to be able to share it with the rest of the country. And one day we'll all be able to get over there and visit. But now I'm going to hand over to Jeffrey. We've got a panel discussion that he's going to moderate, and we have questions that have been logged for us as well, Kayleen, that we're going to bring into the discussion.
Well, while we're getting ourselves organised with looking at those questions, I wonder if I could just draw the panel together now that you've finished your talks and now that you're constituted as a panel, and ask you, of the treasure trove of things that have been presented and that you've heard yourself speak, but you've heard other people speak, has anything struck you about what the others said that might have consequences for your own talk? I heard lots of crisscrossing and lots of interesting, almost folding and refolding the pizza dough to try and understand this concept of value. But my first question isn't that. My first question is, you're going to change anything now you've heard the others speak? Has it added something to what you had to say? Have you got a different perspective? What's the consequences from hearing the others? Who'd like to start?
I think it's great to hear from the New South Wales Health and WA Health states about just the journey that it takes, and also from some of Joanna's research as well, where it just takes such a long time just to get the measures, get everybody on board, and really, I guess at the end, it's trying to embed kind of cultural change in some of these organizations. And obviously there's variation and it's kind of complicated, but I think having that all needs to happen first before you even consider payment models along the way, because often, I mean, saying that, but often payment models can stop people engaging as well along the way. Why would I engage if my budget doesn't directly benefit from my behavior change? Somebody else's budget benefits. There's that I guess, I'm sure you come across that all the time, but it does flag these issues about payment models early on, about what are the barriers in terms of the kind of funding and commissioning models that you use, and that will help you to kind of at least look ahead to help think about carefully how you might change them in order to kind of enable this to happen.
Yeah, thanks, Tony. Paul?
It's so I actually noted down several things, Jeffrey, but just to sort of at a high level think of them, I think there's the issue of identifying what is low value care first of all. So for me, some of it's the overdiagnosis, what's that low end spectrum, etc., which is where we tend to focus. But then I think it's the development of tools, and Joanna spoke about some of those with the stuff that she's doing in the nursing homes, of using that text mining to be able to, and more sophisticated data extraction to work out for example, antibiotic or antipsychotic usage in different places, and which are the problem areas. And that's the second piece, is those tools. And we heard about that with the dashboards, for example, as well. And then the third, and the really tough nut to crack, is the behaviour change part of it. And part of that's conversations with the clinicians, but I think we need a lot more behavioural expertise, behaviour change expertise engaged with this process of sustainable healthcare. But that means this is interdisciplinary across, the epidemiologists in one, the IT people, for example, in the second, and the management and behaviour change people, and economists in the third area about motivations and behaviour change.
Yeah, look, just sitting back, observing this fantastic session, and other people have said what an excellent session it was on the chat. We started off, Paul, with you with a micro view of a specific condition which is overdiagnosed or overtreated. And we ended up with an entire systems view of two WA Health and New South Wales Health, trying to say, how do we change the system towards a value-based approach? juggling all those policy levers and variables that you have to if you're a health department. It was a fantastic excursion all the way through. It was like two ends of the telescope, and then the other speakers were in between, looking at various aspects of it. It was a joy to watch, actually, and a joy to see it unfold. Anyone else want to say whether they would respond to one of the other speakers with their own talk and change it or reflect on the consequences of hearing others? Not compulsory, that's quite a big question, but I see, Enrico, you've come off mute, and Audrey, you have too. Enrico, then Audrey?
Yeah, I was just reflecting a bit, I guess, on language, and I know, Jeffrey, you have been a champion of the Safety 1, Safety 2 story, where we stop talking about what we do wrong and talk more about what we do right. And I was reflecting on that Paul's quite, important language around research waste, overdiagnosis, overtreatment. My own work that I reported on replication and the negative feeling around it. It is a constant surprise, though, that things still do work, and we do a great job. Yes, there are clear challenges with doing research, as I spoke about, but we are getting there. And to me, I guess the real challenge is, as you've said, Jeffrey, we've got this immensely complex system. Each system is different. It's hard enough to know when you play with the levers in a state, A, if they're connected to anything, and B, if you could ever reproduce the results the next time you do the same thing. So we are in, an extremely challenging space. And I just think there is, we have to face the demons, like, for example, face the challenge of research quality and face the unpredictability of health services, but also remind ourselves of how well we are doing incrementally over time. I just think, you look at what we've done in the last 18 months with COVID globally, it is just a landmark response to an existential challenge. So the system does have legs.
Okay, I'm leaving it a little open for the speakers after Audrey, and then we'll move on and take some of the questions which have come in through Q&A. So Audrey, did you want to respond? And for that matter, George.
So I think, the thing that struck me was that we're actually all on the same yellow brick road. And so the question for me is, how do we bring all this activity and energy together so that it's synergistic and multiplies rather than each being in our own silos? So that was the first thing. And I think if we had some common outcome measures that we all agree are, some definition of value, that would probably help as well. And I think particularly when you've got the ability to link to longer term outcomes, that also reframes the way we think about what hospitals are doing. So for example, I particularly like how in New Zealand, they measure the quality of the antenatal care by what the child and what the family's functional status is at 1 year, because that takes in the whole spectrum. And then when Paul was talking about behavioral change, I've often thought I need an organizational psychologist on board, but completely agree.
Fantastic. When you said Yellow Brick Road, I immediately thought, who's Dorothy, who's the Tin Man, who's the Lion, and who's the Scarecrow? But we won't go there. That's probably a good title for a paper one day, Okay, I'm just leaving it open in case anyone else wants to speak. And Joanna, did you come off mute?
Yeah.
Again?
I mean, I think one of the things that, really struck me is certainly we've been very much focused, on aged care, and they seem, they're way behind what's possible in hospitals. But we shouldn't have to go through the pain that the hospitals and the acute care sector has had to go through in order to get to those really sophisticated measures that, Audrey and George were talking about. So it's how do we work more collectively to share the lessons that we've gone through. We've gone through all the electronic health records and shared records through the acute care sector, and yet we're still struggling probably with GP records and with aged care, and we shouldn't have to have a similar, extended history in those sectors. So, how is it we're able to learn and try to break down those silos really of not having to relearn the same things again. This really struck me actually.
But that would be nirvana, wouldn't it? I mean,
Yeah.
but you know, I mean, we live in hope. You know, I mean, what sitting here, I always think, you know, it's the jurisdictional challenges that we have in Australia that I think provides a bit of a break in being able to get things done at a national level. And we see, you know, we've got 2 states here presenting today that are doing things. We haven't got the view from the Commonwealth or the department, which I think is something that's missing and drawing them into this discussion. But I'd like to think that some of that collaboration that's occurred during the pandemic, where we've had a national cabinet, I'm not sure how that's going to be played out in the health area. I mean, a engineered RMAC
Sure.
or whatever, but you know, I think it is certainly a challenge, Joanna, that we really should be able to have a position on. You know, that how can we take some of the learning, sharing it, working collaboratively to do exactly what you say. We don't want the aged care sector to go through the pain that it's taken the acute sector to get where it is, and we're not quite there yet with a whole lot of things. But I think there's maybe renewed energy and enthusiasm. I'd like to think, and I think the Partnership Centre has been a very good model of bringing a lot of this, you know, experience together and learning and sharing from it. So, you know, maybe we put it on as a challenge for us for the next couple of years.
Yeah. Okay, I'm going to use that as a segue, that little sort of into a question that's coming up from Delia Hendry in WA, in fact. George, given federal funding of medical services, how does that play into your wanting to move, and in fact moving to collaborative commissioning across, how does that work across, say, hospitals and community settings? I notice how good it is to use Lumos to link up with GP data, but what about that paradigm?
So in the first phase of the collaborative commissioning program, my understanding is that it's money that has been dedicated and invested by New South Wales Health, and we're using it to build the evidence for more innovative funding models that we can then take to IPA.
Fantastic. Thank you. I'm going to go through some more quick-fire questions now, if you don't mind, panel, and you can pass or play. But someone says, Sian Slade says, can you comment on the composition drivers of increased out-of-pocket costs as one of the paradigms for value-based care? Someone going to take that? Tony, that sounds like a you question.
Yeah. Look, I think one of the issues when we talk about health services and providing care and different kinds of care is that you know, GPs and hospitals, they take people who show up. So access to care is a big issue, particularly people who don't show up, and the way the system is structured, and you know, one of these is the role of out-of-pocket payments, and geography influences whether people show up or not. Out-of-pocket care, out-of-pocket costs are increasing, but when you look at the detail in the Medicare data, you see that there are more doctors, GPs and non-GP specialists bulk billing than ever before. So there's, like, you know, in one sense, there's lower prices for more disadvantaged people and higher prices for richer people. You know, so you see bulk billing rates increasing, but also the fees charged for people who they don't bulk bill are also increasing. So there's a shift in the composition of billing, which is trying to maintain access, people coming. Obviously, if you lower price for the poorer people, they're more likely to come. And if you increase price for the rich people, they don't care about if you increase price for them because they'll just pay it. So I think those dynamics are kind of important, but they're playing out in a pretty unregulated way at the moment. And this is just happening in the market, if you like, and providers are responding to pressures such as, you know, there's a lot more doctors in the system now, so there's fewer patients to go around. And that influences access to care and what doctors do as well. So these longer term trends are important to think about how we're looking at access to care, as well as issues to do with low value care and value-based healthcare once the person's in the system.
Yeah, and there are different kinds of consequences for having more doctors in the system, and yeah, okay, we won't go there in the sense that's a complex sort of thing to go down a rabbit hole on. There's a question coming in from Linda Condon, which is very interesting. What about PROMs and PREMs? We sort of touched on that a little bit, but what about patient-reported experiences and patient-reported outcome measures? And what about those sort of relatively new initiatives for driving or influencing clinicians and changing their behaviour? Who would like to take that up, please?
I'm happy to have a first crack at it, just based on our rollout of the Hope IT system. Probably for a future panel, someone from like Mel Tinsley from the Agency for Clinical Innovation could go into a lot more detail than I can, but I'll do my best. All the evidence we're seeing so far is that this is a fantastic tool for both clinicians and the patients, and is really informing, I guess, giving the patients more of a voice. But from the clinician perspective, the feedback we've received is that it is not only, for some people, it's at first seems like an additional administrative burden, but once they've got into the system and started streamlining it, building it in part of their workflows, it's a rich vein of information, and they're using it to unearth conversations with their patients that they may not have had otherwise. There may be a patient they have seen for years and years and years about their diabetes who's never mentioned their anxiety, but through the use of a generic PROMs tool, it sparks that discussion, and they're able to unpick it and understand the interrelationships between the patient's primary condition, which the patient thought they were coming and seeing the doctor about all the time and thought that was the purpose of their discussions, and brings in a lot of the other, I guess, challenges that the patient may be having. I think it's also really important to help the clinicians from a goal setting perspective. You know, I think we focus a lot on measuring the clinical outcomes, but if we look at individual patients, having that PROMs information available, I think really helps develop tailored goals for patients, because each of them may have different outcomes that matter most to them, whether it's sort of being able to return to work, whether it's from a social perspective, things like that. I think it really tailors the treatment option. It may be the difference between, say, a conservative management approach or going down a surgical path.
Yeah. And look, what inherent in what you said, George, was the idea that PREMs and PROMs, we're on a journey, aren't we? And it's early stages of really understanding the sophisticational power of that patient voice. So it's a journey. Paul, did you want to pick that up?
Yeah, I absolutely agree. They're a very useful tool, and I've certainly experienced that clinically as well in my work as a GP, and would echo what George has said. I do think it's important to remember, though, that that's really important for quality. It's not so clear of the usefulness for low value care. And there's a lovely video from Metro North in Brisbane illustrating how you could have a perfectly done great patient experience for having an unnecessary prostatectomy.
Yeah.
Okay, so I think you have to separate this conversation for the avoiding the low value care rather than delivering a great patient experience for that unnecessary care. Very important for the necessary care. And I suppose it's important for the unnecessary care as well, but you'd actually like to get rid of the unnecessary care.
I'll just respond to that. I agree completely. And I think that's why when approaching and understanding what is value, it requires the triangulation of all those elements. Can't look at one in isolation, but I can't remember the exact paper now, but it's interesting applying the concept of PROMs as well to identifying low value care, because I think we traditionally define low value care based on some of the clinical outcomes, but there's also, there was a paper a while ago, I'll try and find it, arguing that we look at it as well through that patient lens. If it was care that delivered outcomes that they didn't want, then I think we'd classify that as low value as well.
Yeah.
Terrific one, just to add to this.
So Annette and then Audrey. Okay, thank you. No. Keep going.
Sorry, I didn't see Audrey. We ran the research project through the Good Foundation with the Cancer Institute some years ago with the Southwestern Sydney Cancer Network, Prompt Care, which was probably one of the earliest in terms of looking at PROMs and PREMs integrated into the medical record. But what were the two sort of the things that were interesting that came out of that was as you somebody, I think it was George, said that, you know, people identified issues that the doctor wouldn't have asked them about. And a lot of that led to increased allied health referrals, social work, physio, those sorts of things, which was a good outcome. But it also started to change the model of care, that people were not needing to come back to the specialist every 6 months or 12 months because the information was going to their GP and their GP was able to pick that up. So it was really starting to shift the model of care, but it was also moving costs, you know, reducing the costs. The GPs were able to, you know, support the patient because all the information was being shared. So I think it's a very powerful approach. But once again, it gets back down to the, you know, the medical records, the ability to share data, all of those sorts of things. But I think it's got a lot of promise.
Thank you. Audrey?
Thank you. So it's an interesting one because I think, you know, to be honest, we're actually grappling with how you use PROMs and PREMs. And I'm not even sure that I would use it to measure quality. I think it's an excellent tool for a one-to-one conversation between, say, a clinician and a patient. I think sometimes the patient experience data measures the rapport between a clinician and the patient, but we've got areas within the department here who would be very interested in using it as a performance metric. And I think, you know, going back to Paul's example of low value care where you've got positive reports from patients, just because a patient's happy doesn't mean that they got the care that they actually needed. So I think that, you know, within WA, definitely we still need to think about what is the role of PROMs and PREMs and how we actually respond to it.
Yeah, that's a nice point. Okay, I'm just going to go to the next question, which is quite a complex one. I think there's at least 2 questions within it. It's from an anonymous attendee. As we improve our capacity for data interoperability, reporting, sharing the stories that data tells us, how do we ensure to get things like data governance and Indigenous data sovereignty right? Now, I think there's at least a couple of things there. How do we ensure we get things like data governance right? And then how do we use data to have a look at Indigenous data sovereignty, which is another form of governance, I guess? Anyone like to give a first pass at that? Enrico.
I think it's a great question because what strikes me often is that we have 2 mutually exclusive fantasies about the health system. One is that we're going to build a learning health system which is agile and rapid and grabs all the data as we need it to just change what we do. And then we have an equally valid vision, which is that data is sacred, that consent is sacred, and that we should utterly protect privacy and ensure well above reasonable doubt that things don't happen that are untoward or wouldn't be consented. And you can't have those 2 worlds coexist. You just can't, at least not with the mindset we have today. So it's a great question. And I'm seeing lots of pressure on the one hand, say from industry who say, look, we want access to that rich collection of data you have in your health system so I can build my machine learning algorithms on it. In England, there's a lot of concern. For example, right now, GPs are going to be forced to hand over all their records to the NHS to allow for all sorts of unconsented research. And yet, I think in Australia, probably rightly, we're more conservative, and actually, it's quite, you know, we're quite protective of who gets to see data. In fact, so, you know, as we've said, Jeffrey, it's actually very hard for researchers to get access to data through the ethics process. So there are ways forward that kind of split the difference, and one approach is what's called e-consent or dynamic consent. In other words, people either get to pre-specify how their data does get used in the future, or we have very light touch electronic mechanisms that say, would you mind if X or Y or Z happened? But we can't have those two worlds without innovation in governance. So we have to do something differently.
That's very nice, Enrico. Two things in response, Enrico. One is, have you told Chuck Friedman? Chuck is the leading exponent in the world, by the way, if you didn't know this, on learning health systems. And you will get him very worried. He's just putting the finishing touches to his book on learning health systems. So he's going to be worried if you do a critique of it along those lines, Enrico. The second thing is, you know, you've raised that issue of learning health systems. You know, one of the things I heard, and we've done a white paper recently, part of the PCHSS on learning health systems. One thing I heard was how much WA and New South Wales are starting to approximate the characteristics of a learning health system. One that takes all the variables, all the data, all the analytics, and tries to do something with it so that there's ongoing continuous improvement. That was really encouraging for me, knowing how hard it is to do at the state level, the whole of system level. But I take your point, Enrico, you come up against how do you manage all that data and still preserve people's need for privacy and confidentiality and to provide consent. It's this perennial problem. And Joanna, what I heard from you is how you're trying to take steps to encourage the aged care system to approximate more of the characteristics and principles of learning health systems. So that was encouraging too. I don't know if anybody wants to comment on that. We could just leave that as a comment because we've got other questions to deal with. Here's one specifically. In what ways could the, Scott Bell says, in what ways could the outsourcing of hospital services to the private sector by LHNs drive better value for the public dollar? In what ways do current outsourced purchase habits represent poor value? Although that sounds like a New South Wales question, it's actually a general one. And maybe, Tony, do you want to start with that? Is that in your...
Yeah, I mean, I think there is a bit of evidence from the NHS about contracting out and suggests that it's always pretty bad in terms of the outcomes. You know, we've contracted out, the Commonwealth have contracted out the vaccination of aged care homes, for example, to private sector. And so sometimes it doesn't work. It depends on the contract, what's written in the contract, that's what they will do, and only that. But a contract, you can also think of it in a very loose way as a long-term relationship that's built up, regardless of whether money's being transferred or not. But this is about trust and relationships with organisations and how they work. So they obviously contracting out saves money on the bottom line of treasury budgets and things, but that shouldn't really drive our strive for quality.
Yeah. I mean, it's been a thorny question about outsourcing services for 30 years, longer. Paul?
Yeah, so I'd agree with that. I think there's some potential in quality, but quality could also go down, as Tony said. I don't see much of a role for the low value care though, because if you're outsourcing it, you've already, in a sense, made the decision that that care is necessary care.
Yeah.
So you're unlikely at that point to actually get rid of the low value care.
Yeah, good point. Okay, next question, Luke.
Well, just on that one,
Yes,
Jessica,
sure.
we've had I mean, there's been lots of models of outsourcing.
Yes,
We've got, you know, the big ones. Northern Beaches is sitting over not far from us, which is a good example. It's probably the most sophisticated in terms of the role of that hospital and how it came about.
This is northern suburbs, northern beaches of Sydney.
Yeah.
Yeah.
So you've got that's, you know, lots of contracts, lots of lawyers, lots of financiers and lots of money. And to be fair, with the lots of KPIs that we probably don't expect the public system to be measured against.
Yeah.
So there's that model, and then you see the model that we've had during the pandemic, where the public system has outsourced surgical elective surgery to the private sector. But I think it you know, and the private sector's come up a little bit in the discussions here today. When you think that half of, or, you know, or more than 50% of all elective surgery is done in private hospitals in Australia, I think it's very hard to have this conversation that we're having today about, you know, value-based healthcare and low-value care without being able to bring them into the conversation at some point. So that might be something we want to put on the table for later discussion.
Certainly, if you think of the whole of the patient journey,
Yeah.
the patient's going to journey right across a number of settings and a number of opportunities to provide high or low value care.
Exactly.
So, yeah.
And our primary care sector and our specialist sector is predominantly still collections of small businesses,
Sure.
the private. So, you know, we do the structure of the system, you cannot take that out of the equation when we're talking reform.
Very true. Paul, did you still have your hand up, or was that from before? It was from before. Okay.
Lowered.
No, not at all. I just didn't want to make sure. I want to make sure you didn't miss out. Okay. Final question, then I'll ask anybody who wants to just sum up. To sum up, please. Thank you for the excellent presentation, says Luke Sartor. Is the panel able to discuss how value-based care can be maximised in rural and remote areas where fee-for-service may not be sustainable?
Can I make an initial comment? I actually think that the problem in rural and remote areas is often one of access, and where we see overuse in urban areas, we often actually see underuse in rural and remote areas. This is obvious in the Commission's variations work. An example of that would be antibiotics, which in most areas are overused, but you can see pockets, and Aboriginal communities in the Northern Territory are one example of that, where there's an underuse of antibiotics, and that's led to problems with rheumatic fever and purulent pussy ears after otitis medias, etc. So I just wanted to make that clear, that I think actually the big problem is access rather than low value care in the rural and remote areas commonly, though there is some as well.
Yeah. It is an equity issue, though, that whole notion of value-based care provided across the Australian population, and rural and remote is an ongoing sort of challenge. Well, Audrey, without bringing you into the conversation without notice, I mean, you've got a third of the landmass. You know, New South Wales is big, but WA, I mean, how do you provide equity of access across WA and value-based care across the community?
Oh, absolutely. So, yeah, WA is interesting because we're a small jurisdiction by population when we want a seat on the table and they need a small jurisdiction. And we're a large jurisdiction by geography when we want a seat with that hat. So I think a couple of things. So the Atlas did look at variation, and one of the caveats with the data from Northern, particularly WA in the Atlas, is that it actually excluded AMS data. So I actually don't know what the real use of antibiotics or bronchodilators, etc., are above Geraldton. But I think that we often have a conversation about equity in outcomes rather than just access, and that's really to deal with the conversation we often have with communities where they want care close to home. And I think we all know that care close to home, where you've got low volume proceduralists, may not actually be a good outcome. So we do spend a lot of time having that conversation, but we also spend a lot of time looking at virtual care models, telehealth, and frankly, a fair bit of budget just flying people into the metro.
Yeah. Okay, I'm going to draw this to a close. I've got one further hand up, Tony, to respond.
Yeah, it was just, I think there are different funding models other than fee-for-service already being used in some of these rural areas, particularly Northern Territory and Aboriginal health services, which tend to try to pool funds and therefore break down some of those barriers. There's always this issue of you know, providing low volume care in those areas, and it's costly to provide high quality care in those areas, so people do have to travel, and that's can be a big budget issue. But I think I'm not sure that we've really looked at the role of telehealth in some of this. It's not a magic bullet, but I think it can help much more than it does now, probably, and that hasn't really been looked at. Even though with COVID, we've got all these new item numbers that I haven't seen a lot of new evaluations going on about the appropriate use of telehealth in these settings.
We'll be looking at that after the break when we talk about integrated care, Tony, so that's a nice segue. Okay, in PCHSS tradition, I'm going to finish on time and on budget. I'd like to say a couple of things before we all thank the panelists. One is, Tony, I want to take issue with you. We didn't charge any participant. There was no fee paid to any presenter, and therefore economics is totally wrong. There is such a thing as a free lunch.
We're all intrinsically motivated, aren't we?
Yeah, that's right, but we're motivated with no incentives, Tony, so I'm not sure the validity of your talk. No, seriously, thank you for that. It was very good. And the final thing, the PCHSS would like to totally endorse one of the things that Paul Glasziou said. He said, I don't recommend you having an autopsy. And we would like to say, for all of our participants, we highly recommend that. So thank you, everyone. Thank you very much to the jurisdictions and the researchers. This was fantastic. We've got lots and lots of comments coming in saying how fantastic it is in the chat. Much appreciated on behalf of everyone. Thank you, Annette, for sharing.
My pleasure.
Thank you, colleagues in the PCHSS, for organising. And we now have a 15-minute intermission. So thank you on behalf of all participants. For the panelists, we'll have a 15-minute intermission, have a cup of coffee, stretch your legs, and come back for the next exciting episode on integrated care. Thank you very much indeed, everyone.
Bio break. Someone says.
Indeed.